This episode of PediaCast is brought to you by Pediatric Rheumatology at Nationwide Children's Hospital. Hello, everyone, and welcome once again to PediaCast. We are a pediatric podcast for moms and dads. This is Dr. Mike coming to you from the campus of Nationwide Children's Hospital. We're in Columbus, Ohio. It's episode 588. We're calling this one Recurrent Fever Syndromes. I want to welcome all of you to the program. As you know, if you are a parent, fevers are a very common part of childhood, and most of the time they are caused by infections and go away on their own, especially viral infections. We see a lot of those over the course of every winter. But what happens when the fevers keep coming back, often without a clear cause? Well, today we are diving into the world of recurrent fever syndromes, what they are, how we tell the difference between typical fevers and those that are more concerning. We'll explore some conditions that cause repeated spikes in temperature, things like PFAPA, which stands for periodic fever, aphthous stomatitis, pharyngitis, adenitis, which is the most common recurrent fever syndrome in kids. Of course, that's a mouthful. Periodic fever, aphthous stomatitis, pharyngitis, adenitis, which is why we call it PFAPA. Let's break that down, though, here real quick. Periodic fever just means it's a recurrent fever. It's like clockwork. You get it on a set schedule rather than just hit or miss. Aphthous stomatitis, those are just little mouth ulcers. Pharyngitis means you have a sore throat. And adenitis means that you have some swollen lymph nodes, in this case, often in the neck. And so PFAPA is fever, mouth ulcers, sore throat, and swelling in the neck. But of course, there are lots of viruses that can cause those same symptoms. So how do you tell the difference? And that's what we're really going to dive into today. There's also another one called familial Mediterranean fever, or FMF. That's another cause of recurrent fever spikes, temperature spikes. And we'll talk a lot more about that one as well. And of course, in our usual PediaCast fashion, we have a terrific guest joining us for the conversation. Dr. Shoghik Akoghlanian is a pediatric rheumatologist at Nationwide Children's Hospital. She's going to share expert insights and practical guidance for families. It's an important conversation that we hope will bring peace of mind and a clear path forward for parents dealing with recurrent fevers. Again, ones that sort of come and go like clockwork. Our discussion is coming up, but before we dive in, I do want to remind you the information in every episode of our podcast is for general educational purposes only. We do not diagnose medical conditions or formulate treatment plans for specific individuals. If you're concerned about your child's health, be sure to call your healthcare provider. Also, your use of this audio program is subject to the PediaCast Terms of Use Agreement, which you can find at PediaCast.org. So let's take a quick break. We'll get Dr. Shoghik Akoghlanian settled into the studio, and then we will be back to talk about recurrent fever syndromes in kids. It's coming up right after this. Dr. Shoghik Akoghlanian is a pediatric rheumatologist at Nationwide Children's Hospital and an assistant professor of pediatrics at The Ohio State University College of Medicine. She has a passion for supporting children and families impacted by recurrent fever syndromes. What exactly are these? What causes recurrent fevers? And how are they diagnosed and treated? Answers to these questions and more are coming your way. But first, let's offer a warm PediaCast welcome to our guest, Dr. Shoghik Akoghlanian. Thank you so much for visiting with us today.
Thank you. Thank you for having me.
Yeah, we're really excited to talk about this because it's a thing that as pediatricians, we learn about these and we do see some kids here and there with them. But for parents, when it happens, they're really caught off guard and aren't understanding. And so we really want to get the word out and raise awareness about what these things are. So first, what exactly qualifies as a fever for one? And then why do some high temperatures not necessarily count as a true fever that's indicative of like an infection?
Sure. So as you said, it's definitely catches them off guard, and it's definitely scary because anytime your child has like a temperature, they look miserable, and you don't know what to do for them. So we typically call normal temperature anywhere between 97.2 to 99.5, and that's like normal temperature. So often I hear patient coming in and saying like, "Oh, my child has a temperature of a 99," and that's kind of like a high temperature, but it is not still counted as a fever. So for fever, we say anything above 100.4 Fahrenheit is a fever, and that's what I usually when I see these patients, I say, okay, please do not give any antipyretic medication, so no ibuprofen, no Tylenol. Just let's see if this temperature is going to get higher to the point that we actually do call it a fever. Therefore, there is a whole lot of investigation needs to be done.
Yeah, yeah. And so 100.4 and higher is really our definition of a true fever. Because, sometimes folks will say, well, they were 99 and then they call it a low grade fever, but that's really not a thing, right? It's either
Correct.
you have a fever or you don't have a fever. And
Yeah,
100.4 or higher is the definition of what we would consider to be a fever.
correct. Yes.
Okay. And of course, this is really, really common for kids to have fevers. I mean, we see this every day in pediatric practices and emergency departments and urgent cares. Like literally, many, many children every single day in every community have a fever. So when are we worried about fevers and not worried about fevers? And I guess we have to look at the things that cause the fevers to understand whether we're worried or not. So kind of what are the general things that lead to fever in children?
Yeah. So as you said, it's extremely common. So pretty much any child, like, yes, at some point in time, they have a fever. And, as like common things are common, viral infection, bacterial infection are the most common things. And often this is important to talk to our patients, especially if these younger ones, they just start to school or start to preschool, daycares. It's extremely common for them to have some like infections. Typically, these are the infections that they run its course. Sometimes it's frustrating for parents when they take their kids to the primary care doctors and then they say, okay, well, your child doesn't have any signs to suggest bacterial infection and it's only viral infection. It needs to run its course. And it's my job sometimes is when I see these patients with recurrent fever to actually reassure them and tell them, up to 14 independent infection for a kid who just started daycare, it can be completely normal. And sometimes that's frustrating for the parents.
Yeah, yeah, absolutely. And we see this every single winter, and folks who work in pediatrics and take care of kids in terms of their health and wellness understand exactly what I'm talking about. But as you said, kids can have as many as 14 infections a year, and those often are kind of compressed into the school year because that's when kids are around each other and sharing their germs in the classroom. And the way that our immune systems work is that we have to get sick with the virus the first time it comes around. It's training our immune system to fight that particular virus off the next time it comes around so that we're not quite as sick the next time. And of course, there are literally hundreds and hundreds of different viruses and virus strains out there. So as a young kid, every time you get exposed to a new one or a new strain, you're going to get sick. Whereas an adult, you've had all of these viruses when you were a kid, and so you have hopefully built up immunity against them. Vaccines are another way that we build up immunity against more dangerous infections. And so if you're looking at 14 viral infections and each of them can last 1 to 2 weeks, and then you compress that into the school year, you really can have a situation where it just seems like your kiddo is sick all the time.
Exactly.
And that doesn't necessarily mean something is wrong. On the other hand, we are talking today about recurrent fever syndromes. So there is a sort of a different disease process that causes recurrent fevers that's not associated with these viral infections. And so if recurrent fevers are so common during the school year, then how do you tell the difference between fevers that are just virus and it's okay and recurrent fevers that, hey, there's something else going on? How do you tell the difference between those two things?
So the first few episodes of when the child kind of presenting with recurrent fever, it is definitely important to you get checked at the primary care doctor. Urgent care depends on how sick the child is. Very often is first thing again. Common things are common. They gonna probably not do a whole lot of testing. But when this happens again and again in a very in a pattern where all the symptoms seems to be happening again and again, and then let's say if primary care doctors and urgent care doctors, they're gonna kind of investigate a little bit more. That's why it's really important to look at the history. So yes, they are maybe there once, or maybe the on-call doctor are looking at them and they're like, okay, well, we'll treat this as a viral infection. Often actually parents bring this up to say, oh, we were just here, and then it seems like Johnny had exactly the same symptoms last month. And then let's say sometimes we take it a step further where actually they do further testing. Maybe they do a nasal pharyngeal swab looking for viruses. Of course, even if that's negative, this doesn't mean that they don't have that virus. But if this continues to happen, often these kids actually present with a sore throat. So kind of what it looks like is strep, but often I see they get swabbed for strep, for a rapid strep testing, and then often it comes back negative. And honestly, I see this all the time where parents actually get frustrated. So they actually stop going to the doctor. And I'm like, why this happen? Because they're like, every time we go, it's just nothing to do. And they tell me it's a virus and go home. I cannot tell you how often I see that.
Yeah, yeah. And that is frustrating not only for parents, it's also frustrating for physicians, because we want to get the right diagnosis and tell, the family what we think is going on. But hopefully we are not feeling so rushed in exam rooms that we're not taking time to really get a good history, because these viruses, of course, are often going to be associated with some other very common symptoms like runny nose, congestion, cough. You might have vomiting or diarrhea. So if those things are present with the virus, and especially if there's it's wintertime, there's other kids in the house with very similar symptoms, and that all points toward viral infection. But when you have a fever with really not much else and no one else is sick and it keeps happening, and maybe even in the summer it's happening, then that does start to raise your radar a little bit that there might be something else going on, right?
Absolutely. Actually, that's a good point. So just to give you an example, so a few years ago when we got hit with the pandemic, that was a time that we saw a whole lot of referrals actually for recurrent fever syndrome because, everybody was on a lockdown, everybody was, mask outside, the kids are not in school, everybody's, Zooming through the school, so not much contact. And that's when the kids with recurrent fever showed up. Johnny is sick, but actually, well, nobody else is sick, and we have not been exposed to anything or anybody who was sick. And then that's exactly when we got this big spike in the referrals for recurrent fever.
Yeah, which is a little unsettling because that means that there's probably a lot of kids who do go undiagnosed with these during non-pandemic times when when it's more likely just to say, oh, they got a fever because they were at school and around other kids. So I guess that was one of the silver linings, so to speak, of the pandemic, just in terms of it did help to diagnose more of these kids with the actual thing that's going on, and then we can treat them and hopefully improve health outcomes, right?
Exactly. Yeah. I mean, I think it's going to take longer because, and it might be that they just have infections, right?
Yeah.
So it's just going to take longer. So probably a couple episodes.
Do these things, and we'll talk a little bit more about what exactly causes them, but do they tend to run in families? So is this something where a parent, if you have a sibling or another child who has been diagnosed with a recurrent fever syndrome, is your kiddo more likely than to have it, or is it not run in families?
Yeah, it can. Depends on what we're talking about. So when we talk about really recurrent fever syndrome, it's not like one disease that we're talking about. Actually, we're learning a lot more about these recurrent fever syndromes within the last probably 2 decades. And there's some of them, they are genetics, right? Genetics play a great role in these patients, specifically speaking, actually, something called Familial Mediterranean fever, or FMF. This is actually about 60% of these patients. They have a family history of, somebody in the family has FMF. Therefore, they present with these recurrent fever, they present with the classic symptoms that's associated with this syndrome, and then your diagnosis is pretty much, yeah, actually you do have FMF. Yes, it does run in the families.
Yeah.
Others are extremely rare diseases, and sometimes people are actually never heard of this. So yeah, it varies, depends on which specific diagnosis we're talking about.
Yeah. And that's familial Mediterranean fever.
Correct.
Yeah. And that is something that is genetic and causes recurrent fevers. Is that through the immune system that the fevers, as we think about fever and what causes fever, an invasion from a virus or a bacteria causes our immune system to react, and a lot of chemicals get released, and some of those chemicals are telling white blood cells and other parts of the immune system where to go and what to do. And so our immune system, one of the sort of side effects of it is fever. And so you can have the immune system, what we'd call an autoimmune disease, where the immune system there's not an infection there, but it still does what it activates. And so we get the fever. And then we also have a thermostat basically in our brain that adjusts our body temperature. And if something's wrong with that, that could also cause you to have fevers too. Are these the kind of processes that happen in these recurrent fever syndromes, or is it something completely different that I'm not thinking about?
No, actually, you are right. So this genetic mutations that happen to these patients, that they have this specific recurrent fever syndrome, that actually does cause this immune dysregulation. So often I explain to the families, yes, this is not something you get like a virus or a bacteria, but your body is reacting to this stimuli. Now, it can be a trigger. This trigger can be a virus. This trigger can be a stress of any sort that actually triggers the immune system that is actually not programmed correctly to release, as you said, these proteins, which we call them these cytokines. Specifically speaking, there is this like the interleukin-1 and interleukin-6. These are like a fancy fever protein, I would call them. And then that increase of these proteins can actually cause the body to have these fevers.
Yeah. So let's say we have a kiddo that has recurrent fevers. They don't necessarily have viral symptoms with them. And, we're concerned that they could have a recurrent fever syndrome that's where their immune system is just causing the fever for unknown reasons. How do you diagnose that? And then how do you treat it?
So the first thing is actually just keeping track of these fevers. So very often when I see a patient, I tell them, by definition, actually, when we say somebody has recurrent fever syndrome, or actually we didn't talk about this, we also call it just also known as autoinflammatory syndrome, or actually systemic autoinflammatory syndrome, which stands for like SAID. So again, systemic autoinflammatory syndromes. And these are the category of diseases that we're obviously talking about today. And by definition, these are the 3 or more episodes that happen within the 6-month span. So when I see these patients early, I'm like, well, we need to keep track of what's happening. So keeping a diary of all like the symptoms, the fevers, what are the symptoms associated with these fevers, whether it's like sore throat, whether it's like a swelling in the lymph nodes, or whether it's abdominal pain or like even eye symptoms, eye swelling, joint pain, or even limping sometimes. Rashes are very, very common in recurrent fever syndromes in general. So I usually tell all my patients, like, we have phones, we use them for all kinds of, reasons, but it will be extremely important and helpful to actually take pictures. So, often these patients, when I see them in the clinic, they actually had the fever episode and they looking absolutely amazing in the clinic. Their physical exam is completely fine. They don't have any rash, any lymph nodes. So a lot of times is the first step to diagnose these kids is actually just keeping a diary for other patients. And I usually hand them a calendar, say like, hey, please keep a track of it. Now, why is that important? Because as I said, there's over 50 different diseases, specific diseases for recurrent fever syndromes. And then it seems like every one of them have, I would say, specific pattern to it, to like how often these fevers are lasting for, what are the specific symptoms that the child present with at the time of a fever, and how often these fevers are occurring. So I think it's important to talk about the most common and benign recurrent fever syndrome, which is actually called PFAPA, which we can definitely talk more about that.
Yeah, let's do. So PFAPA, PFAPA, what does that stand for and what is it? Because this is one of the more common ones, correct?
Yeah, so this is actually by far the most common recurrent fever syndrome in childhood. And then this is when, pretty much every primary care doctor or pediatrician should know about and should know, how to diagnose it and diagnose it and also potentially treat it. Definitely welcome to send a referral if something is atypical. But what is PFAPA stands for? So it stands for periodic fever of the stomatitis, that's like the sores in the mouth, pharyngitis, it's kind of usually present with a sore throat, and adenitis. That's when the kids have a swollen lymph nodes, typically like a cervical lymph node, so like in the neck is swelling, basically. These lymph nodes, it's swollen. And when you think about that, that's somebody who has sore throat, fever, and lymph nodes. That's kind of, you may think about strep, right? So these are the kids that I often see that they got like a swab for strep actually a couple times. And obviously the rapid strep testing comes back negative.
In enteroviruses and adenovirus both could also cause similar symptoms as well, correct?
Absolutely.
And those are very common. So we do see a lot of viral pharyngitis. And now I'm asking myself, how many times have I diagnosed viral pharyngitis and it really is PFAPA instead? Because it's not the first thing on our mind, especially when we're seeing a whole bunch of sick kids all day long who have very similar symptoms. So that's why I say it's frustrating for both parents and for physicians too.
Yeah, that's exactly why it's like extreme. And you probably are, correct. It's probably is viral infection, but it's just the recurrence of these. So actually one of the, almost pathognomonic for PFAPA. So it's kind of every time I hear this, it's kind of likely PFAPA. It's actually the regular periodicity of these flares. So parents come and tell me we think Johnny's gonna have a fever on September 20th. And I'm like, okay, well, usually you're not going to be able to predict when your son is going to have or your daughter going to have actually adenovirus. And they had this for a couple months already that they know and they can predict when this fever is happening. And typically that for me, I'm like, I send them home and actually I tell them, hey, please, can you call me if your child actually does have a fever on September 20th? Because that for me
or
is
even a day or two
flag.
from that is still going to be impressive.
Exactly. So I'm like, okay, well, this is probably PFAPA then.
Yeah, yeah. And so this is a good case for seeing your regular doctor when you can. Because
Exactly.
if you go to an urgent care and, as an urgent care and emergency medicine physician myself, I'm not trying to drive away business, but we are much less likely to notice those patterns than your regular doctor, because then all of your visits are with this, hopefully with the same provider, and they can start to notice, hey, were you just here a month ago? And wasn't it a month ago before that? And a month ago, but so you can start to see that pattern because you're seeing the same provider in your medical home time and time again. And so if you're able to see your regular doctor when you're sick, you're much more likely for them to be thinking about other things than just the most common things.
Absolutely. Absolutely.
So then if you do have a kiddo that you determine has PFAPA and you've basically you're thinking in that direction based on their history and the physical exam findings, how do you determine that really is what's happening, or is it just a clinical diagnosis? Is there a test or something that you can do to show parents, hey, this is what it is?
No, actually, unfortunately, there is, for most of these diseases, there is not really specific test that we send off. So typically, it's just the symptoms, and there is a bunch of criterias, or actually different criterias for every single autoinflammatory disease, and it's just like really clinical diagnosis, which makes it really hard because sometimes like in pediatric rheumatology in general, actually, we don't deal with like a black and white kind of diagnoses. We have like different shades of gray in between. And sometimes things can overlap and it can be very tricky to diagnose them with the specific disease. So it'll be like, I usually tell my patients, it would be like very smart if I tell you like, this is what's exactly I suspect is going on. PFAPA is probably the easiest to do so. And as I said, like there is this the regular periodicity is a big one. Typically we do get I would say 1 or 2 sets of blood work for these kiddos. Typically, the inflammatory markers are elevated at the time of the flare. It's extremely important to know that these kids are very well. They are completely normal in between the episodes of fever. So they're back to normal, playing, growing, doing everything that any child in their age is doing. So they're completely well between the episodes. And actually, even if we do repeat the testing, the blood work, I usually get a set of a blood work at the time of a fever and another set when they are well. And typically all these inflammatory markers, I do expect them to be completely normal at the time when they are well.
Their inflammatory markers when they have the fever, though, would be expected to be high. White blood cell count, is that often high, or is that normal when they're having a fever episode? Or it could go either way.
So most of them, they are elevated. There is very few ultra-rare diseases that, yes, you can see low counts. Typically they are elevated, and so is all the inflammatory markers. So we talk about ESR or CRP, like the C-reactive protein. These are usually high at the time of a flare, and they completely get better when the child is well.
Yeah. If you don't do anything when the flare happens, how long does that usually last?
So if we're talking about PFAPA, the fever lasts anywhere between 3 to 5 days in general. When the child is sick, they are miserable, have like painful oral ulcers, and that can actually be very hard because these kids have some decreased, fluid intake. Sometimes they end up dehydrated. Sometimes they have very large lymph node, and for the first time, and they are usually painful. So the first or second episode, they end up actually in the ER or admitted because they need IV fluids. And you're definitely concerned about like an infection, right? Like an infection in the lymph node. So therefore, they end up in the hospital sometimes.
And then if you do diagnosis, is there something that you can do then at the beginning of the fever, and it's one of the predicted fevers, to arrest it, to stop it, so they don't have to have the symptoms for the whole 3 to 5 days?
Yes, absolutely. Actually, we as a pediatric rheumatologist, it's very familiar for us, is an organization actually through North America. It's called CARA, which is the Childhood Arthritis and Rheumatology Research Alliance. So CARA, CARRA. And for CARA, there is different has a lot of over actually 82 different sites in the US and some outside. And experts meet, and then we, after a long and laborious meetings and research and data review, we come up with these called like CTP, or consensus treatment plan for our diseases. Because as you know, like in pediatric rheumatology, we see a lot of like rare diseases and even ultra-rare diseases. So for PFAPA, after actually consensus treatment plan was published several years back, and there is different treatment options we do for these kiddos. So as you mentioned, if this and one of them actually, as you mentioned, these fevers are predictable. So for some reason, one single dose of a prednisone, which is like the steroids, prednisolone or a pred, these are all different names for the same thing, basically. So one dose of oral steroids at the time of the fever, or at the onset of the fever, actually may shorten the duration of the episode, or maybe just completely actually abort the episode completely. So the child gets the first dose. Some of the children, they may need a second dose if the fever doesn't resolve completely within 24 hours. Typically, that's also one of the criteria actually CARA has for PFAPA. So if the fever resolved, that kind of is another sign for me that actually, yes, this is a PFAPA.
Yeah, because if it were really a viral illness, you wouldn't expect 1 or maybe 2 doses of prednisolone to help them feel better that fast.
Exactly.
Yeah. So it's kind of confirmatory.
Exactly. I actually tell my patients this is not just like it's like a diagnostic trial, just as much as it is a therapeutic trial.
Yeah. Now, is there anything that can be done to prevent the fever from happening in the first place? So like a maintenance sort of thing so that it just doesn't happen. I suspect that the issue there is that we don't necessarily want to diminish the effectiveness of the immune system in between episodes, because then you may be more prone to other infections. So it's kind of a balancing act, right? Between, you want the immune system to work when you need it to work, but you don't want it to fire up on its own either.
Right. That's kind of like a general rule for all our diseases in rheumatology, where we actually give some immunosuppressive medication, but then we also may decrease the risk for having infections. But for PFAPA specifically, so there is a couple other medications that we can use to prevent fevers from happening. One of the medication actually called cimetidine. This is a medication for stomach pain or medication similar to actually Pepsid. For some reason, when we give it to these patients, they actually stop having fevers or have less fevers. Another medication actually called colchicine. Colchicine actually is one of our first go-to medication for most of our recurrent fever syndromes. So even if it's genetic, so for example, familial Mediterranean fever that we did bring up earlier, it's actually the treatment of choice for that as well. So it's a tricky because these are we tell patients like, your child is not having fever every day, but they need to take these medications either once a day for the colchicine or twice a day for the cimetidine to stop actually having fevers. And so it is going to be a lot of, counseling about compliance because, that's going to become an issue.
Yeah.
Actually, there is one other thing I don't think we hit on, but this is extremely important. When we give these steroids, I always warn the family because after we use it for so many, let's say, couple episodes or couple months, these fevers become irregular and also may become more frequent, which is the challenge, which I feel like most of my patients be like, well, we're not okay with this. We used to know when Johnny was having a fever, but then now we don't. And these fevers seem to be more often and we're giving them more steroids. And that's why it's extremely important then to actually talk about different options of treatment.
Yeah, yeah. And also important, I would think, to have a pediatric rheumatologist involved in your care, because there's going to be a lot of nuance to this, and you are going to see all the different variations because you get kids referred to you, and so you see an unusually large number of these kids compared to primary care doctors. And so you're going to have a better idea of what you have seen that has worked and what has not, what doesn't work as well, and how some families may need a different, a different management plan than others, even though they might all have PFAPA.
Exactly. Yeah, usually it's kind of like a team decision because, as I said, we do have these consensus treatment plan. One other treatment we didn't mention about is actually tonsillectomy. So for some reason, we don't understand yet. There's so many studies, going on with just studying the tonsil tissue, but actually taking the tonsils out, so getting a tonsillectomy for most of these PFAPA patients is curative. So sometimes it's just like a family discussion to, what do we want to do? Do we want to just give, ibuprofen and Tylenol and let it run its course? Because after all, PFAPA is a disease that kids grow out of. So it's just a matter of time. As much as, I see patients who are like, we don't want to do anything. Let's just let it be. And then we give ibuprofen and Tylenol. However, when the kids start going to school, there is, so many school days they're going to miss. It's a big burden for parents even that they're working. I had my kids in the daycare, and if they have a fever, you need to go pick them up, or even from the school, you have to go pick them up. So they call in off work, and it's just really a big burden for the parents as well. So sometimes I tell them, we really need to do something about this.
Yeah, for sure, because that starts to really interfere with your quality of life and your family's quality of life.
Absolutely.
When you mention the tonsils, that makes me wonder, is there an environmental cause of this? Because if something is getting in the mouth, we know that tonsils are sort of the first place that things in the air, what we would call antigens, come into contact with our immune system. And so if you get rid of the tonsils, then you don't have that contact. So do we think there's something in the environment that could be associated with PFAPA? And then it may look like it runs in families if families have the same environment.
Yeah, actually, that's definitely one of the hypotheses as well. And then there is some new, because we were talking about yes, could PFAPA run in the families? There is some newer data from a National Institute of Health that there is a genetic variant that can actually, of course, it's not confirmed yet, but it can be the cause of PFAPA. As for now, as I said, we don't know the reason why this happens, but there is actually an ongoing trial right now to see if this variant is truly the cause of PFAPA. And this actually is recruiting. You can find the link for it in clinicaltrials.gov. And then they just need basically a lot of patients, so over 1,000 patients to actually confirm this link.
Yeah, yeah. There's a lot of overlap in this area with rheumatology and with allergy then too. Just to confuse things even more. Right?
Yeah, we actually care for our patients with, in general, with our infectious disease colleagues. So, it's not surprising the kids is getting sick all the time. So they can be referred to immunology because they may think also that there is some immune deficiency of some sort. As I said, infectious disease colleagues and definitely us in rheumatology, pediatric rheumatology.
Yeah. I tell you, it's quite frustrating for the families and for us physicians as well. And when you mentioned there's actually 50 different diseases that can do this, fortunately, there's just a handful that are the most common, but it can make it more difficult. And so hopefully families understand that, like, we're doing our best, but we might not be able to get the right diagnosis immediately, because especially when things aren't as common. And then when the symptoms are things that are caused by very common things, that makes it even more difficult. The other one that you had mentioned, familial Mediterranean fever, or FMF, that one is less common than PFAPA, correct?
Yeah. So PFAPA is the most common benign recurrent fever syndrome. FMF is the most common genetically mediated autoinflammatory syndrome. So it's actually very common in the area of the world and like around the Mediterranean, as the name applied, right? Like it's very much common. The incidence is significantly higher, but it is the most common monogenic autoinflammatory disease. And we actually, with bigger communities, so with immigrants, I have many patients with familial Mediterranean fever as well.
Oh, okay. So it is also fairly common in your patient population. Anyway.
Yes, because we get referrals, as I said, like from, a couple hours away in nationwide.
Now, is this one only fever, or are there other symptoms associated with it, like with PFAPA?
So fevers definitely present, just almost 100% universally present in patients with FMF. The most second symptom actually is abdominal pain. These patients come with severe abdominal pain at the time of a fever, and then you think of a child you're seeing who's like let's say 10-year-old with high fevers and severe abdominal pain. You're gonna sometimes even the physical exam suggests that they may have actually surgical abdomen. Many of these patients, they even again, our providers are very concerned about appendicitis, and that's kind of by far one of the most concerning one. But FMF episodes of fever, they are usually short. So about 2 to 3 days, and the patient's completely better. They are absolutely miserable in between, or absolutely miserable at the time of a fever, but they're, again, 2 to 3 days, they're completely better. Now, there is some other symptoms that happen with PFAPA. So sometimes joint pain. So we call
I'm
it
sorry, this is with
arthralgia.
FMF.
I'm sorry, yes, FMF. Yes, thank you. So for patients with FMF, so other symptoms including, like, we call it arthralgia, which is like joint pain, or even arthritis. And then there is different specific rashes that also can happen with FMF patients. So again, keeping track of these episodes. And we actually diagnose almost more than, I would say, 90% of these patients in the pediatric ages. So like usually the first 2 decades of life, we diagnose almost 90% of these patients. And as I said, these are the patients that they have a family history of FMF. Or if they come and tell me, for all my patients with recurrent fevers, it's extremely important to ask about ethnicity, because different ethnic groups have this. The incidence for these diseases are extremely high. So for familial Mediterranean fever, like our patients, Turks, Armenian patients, Ashkenazi, non-Ashkenazi Jews, it's extremely common. So if you see like just fever patterns that suggest FMF, and they have background or ethnicity that suggests also FMF, so these are the patients that typically they need colchicine right away.
So this is different than juvenile idiopathic arthritis, which can also have fevers and joint pain and rashes.
Yeah. That's a completely different game ball, but yes. So we actually, juvenile idiopathic arthritis, which stands for JIA. So juvenile because it's less than 16 years of age, idiopathic which means we don't know why it happens, arthritis. So it's one of the most common diseases that we see in rheumatology. So about like roughly 75 to 80% of all our patient populations with JIA. But then there's different types of JIA. Now, one of them, which is called systemic JIA, is the one that presents with the fever, the rash, and the arthritis. Surely it's like the triad, right? Like fever, arthritis, and a rash. But then there is, and this is called systemic JIA. Now, we have several other subtypes of JIA, and none of the other subtypes actually presents with a fever. So they just present with the arthritis, which typically when I say arthritis, I'm referring to persistent joint swelling and pain or limitation in a joint.
So how do you diagnose FMF then, especially since there is some overlap with systemic JIA? As we're throwing letters out here, and I'm hoping that families, just understand the complexities of what we're talking about. It's amazing that we understand what we do understand, to be honest.
Yes. And then it seems like the more we think that we're understanding more, it seems like we need a lot more. We kind of realize that, there is a lot more to uncover. So FMF and systemic JIA is completely different things. So while FMF presents with recurrent fever, so again, these are episodes of fever. So the child is sick, has fever, abdominal pain, sometimes rashes, sometimes joint pain or arthritis, and then it gets better. And then it happens again. So for systemic JIA, it's a completely different, symptoms. So you have a fever and the joint pain and the rash. Now, sometimes not all of them are present at the same time. Sometimes the fever starts, and until a few days later, when the rash pops or the arthritis, the swelling and comes up. So systemic JIA is not recurrent. Okay, so these are the kids are sick, they have high fevers, they're miserable, and typically systemic JIA patients, they end up in the hospital with a fever of unknown origin, we call it, so FUO. And then these are the patients that they end up very often actually in the infectious disease service because they think it's an infection because, common things are common again. So we do very, very thorough infectious workup for these patients. And typically when everything comes back negative, our colleague in infectious disease, they call us, it's like, hey, we have, let's say, Johnny here, and we run so many testing and everything is negative. We don't think there's any pathogen that causes the disease. These are the patients that they are really actually sick. Sometimes their white count is extremely high. And that one thing we do need to rule out for these patients is actually neoplasm or like malignancy in children.
Mm-hmm.
Exactly. Leukemia or lymphomas, because they also systemic JIA patient, they may have a lot of enlarged lymph nodes. So sometimes we may need to do like a bone marrow biopsy or a lymph node biopsy because the treatment is completely different, right? Like if they have systemic JIA versus if they have leukemia, we need to get to the diagnosis first before we start any treatment.
Yeah. Now, with FMF, is the recurrence as regular as it is with PFAPA?
No, actually, it's very irregular. Sometimes the stress can actually trigger the flares, but it's very irregular. So it's not predictable.
Yeah. And that is one thing in the clinical history that you can use to differentiate FMF from PFAPA.
Absolutely.
Yeah. Now, even though it's Mediterranean and we talk about the ethnic groups where it is most common, we still want to keep it in mind for everyone, correct? Because
yes.
especially, in the melting pot of the United States, there's a lot of sharing of genes. And so we don't want to rule something in or rule something out strictly based on ethnicity, correct?
Absolutely. Yes.
And then in terms of, you said PFAPA kids typically outgrow it. What about with FMF? Is that something that also goes away as they get older or no?
Yeah, no, not really. So when we talk about FMF, we said it's genetic, and typically this is an autosomal recessive, which means we need the two genes so one from the mother's side, one from the father's side to actually the child present with this. And we do have genetic testing to confirm this specific disease. And we send this panel. So let's say if the patient comes back positive, and the testing becomes diagnostic for FMF, these are the patients that we need to actually treat them for life to actually prevent some of the complications with FMF, something called amyloidosis. And what that is basically a result of continuous inflammation when this amyloid protein actually gets deposited in different parts of the body. One of the most important ones will be like when it gets deposited in the kidneys, and it can cause end-stage renal disease, and that sometimes can be irreversible. The problem is these are the patients that they are in their 30s or 40s or even 50s when they end up with dialysis, and sometimes they need renal transplant. So these are the patients that we need to treat them. The great news is the colchicine is a medication that works in this group of patients, or let's say most of these patients, and it actually does prevent amyloidosis. They need it every day.
This has been a really fascinating conversation, and it's so interesting. We'll have to have you back at some point and just do JIA, juvenile idiopathic arthritis, because we could easily do an hour on that alone.
Absolutely.
But what is your take-home message for parents whose kids have fevers frequently? Like, from a parent standpoint, when do I bring this up? When am I concerned? When do we need to go see a rheumatologist? Kind of break it down for parents. What's the most important message here?
Yeah. Now, keeping track of what's happening is really the most important thing. And when things start, it's extremely important to go and be seen. As you mentioned earlier, better if it is with your primary care doctor, but totally understand that your primary care doctor may not be there all the time. And then I would really encourage all the parents to actually bring up and say, yeah, Johnny was sick the last time or last month. We had similar episodes. So I think just keeping track of what's happening and then just bringing their concern that, we think there might be some recurrence here. And that's when the primaries will say, yeah, you know what, let me just go ahead and, send a referral to rheumatology. However, in the meantime, it will be extremely important to keep a diary of all the symptoms. So when they come to me, at least I'll be able to look through, we said we need 6 months to diagnose these, right? Like by definition. So at least I have a couple months of symptoms so I can look through and say, this looks like PFAPA, or this doesn't look like PFAPA, and we need to investigate more. I think also being patient is helpful because these things take a long time to diagnose, and I see a lot of parents get frustrated. They need answers right now. And actually, what's even more frustrating, that let's say we are seeing a patient that's not PFAPA, that's not FMF, but it's one of these ultra rare different diseases that we have that they cause recurrent fever syndromes. And we need to send the genetic testing. The genetic testing takes about, 4 to 6 weeks, sometimes 8 weeks to come back. But the tricky part is about 40% of the times, sometimes 50% of the times, the genetic testing comes back. That's not diagnostic. We actually see many of these different variant of unknown significance, we call them. So it's called VUSs, that basically, they don't really diagnose a child with anything, but then unfortunately, they don't give me a specific diagnosis for why they actually have recurrent fever syndromes. We actually do call these patients unspecified systemic autoinflammatory diseases. So, and sometimes not, all parents are open to say, yeah, I definitely need a name for it. I'm like, well, they kind of do have a name. It's just unspecified yet. And I'll tell you, I have patients that I cared for over a decade. And after that, we were able to actually find out to what specific new diagnosis they have. So it's fascinating. Although the treatment, sometimes it's still the same. We still treat them. In rheumatology, we seem to deal with many of these diseases that they are unknown. And we still treat them. We still have different the art of medicine for pediatric rheumatology is definitely a thing. And we treat them with the most appropriate medication and get them feeling comfortable, take care of their inflammation, stop the fevers from happening, etc. But we may not have a name for it.
Yeah. But we might in 5 years, or we might in 10 years.
Absolutely.
As we continue to understand genetics and are able to diagnose genetic conditions.
Absolutely.
So patience, that is a good. And I think hopefully we've done a good job over the course of this episode of really shining a light on how complex this can be and why patience is needed all around. But at the end of the day, everyone has your child's best interest in mind and really wants to get to the bottom of what's happening and get the correct diagnosis and the right treatment so that we can have the best outcomes. It's just unfortunately, unlike other things where we have a real quick test, with these, we don't often have a clear test to say yes or no. It's great. As you said, gray area where the rheumatologists live is the gray area, the gray zone.
We have our genetics department. We have, like in the Recurrent Fever Clinic, we have our genetics and a genetics doctor and then genetic counselor, which help us out. And in Nationwide, we're doing absolutely amazing job where we can even, if the initial genetic testing comes back negative, we usually start with a smaller panel, and then sometimes we dig even more. I usually tell my patients is just looking at the stars with your own eyes versus looking at the stars with a telescope versus looking at the stars from NASA. So we get to different testing, depends on how we think the child is doing or how much concerns we have that, yes, this is actually a genetic disease. So our geneticists are absolutely amazing at Children's to help us out.
Yeah, absolutely. Well, we are going to have lots of supporting links in the show notes, both for parents. Also, if you're a pediatric provider who is listening, we are going to have a lot of science-y resources for you as well in the show notes. So be sure to head over to PediaCast.org. This is episode 588. And you'll find all of those resources. Some of them we have talked about, the classification criteria for autoinflammatory recurrent fevers, the consensus treatment plans for PFAPA. We have the syndrome of undifferentiated recurrent fever, just lots of articles for folks to explore. So if you want to learn more about this, we'll definitely have something for you over in the show notes. So once again, Dr. Shoghik Akoghlanian, pediatric rheumatologist at Nationwide Children's Hospital, thank you so much for visiting with us today.
Absolutely. Thank you so much for having me.
We are back with just enough time to say thanks once again to all of you for taking time out of your day and making PediaCast a part of it. Really do appreciate that. Also, thanks again to our guest this week, Dr. Shoghik Akoghlanian, pediatric rheumatologist at Nationwide Children's Hospital. Don't forget, you can find us wherever podcasts are found, or in the Apple Podcast app, Spotify, iHeartRadio, Amazon Music, Audible, YouTube, and most other podcast apps for iOS and Android. Our landing site is PediaCast.org. You'll find our entire archive of past programs there, along with show notes for each of the episodes, our terms of use agreement, and that handy contact page if you would like to suggest a future topic for the program. Reviews are also helpful wherever you get your podcasts. We always appreciate when you share your thoughts about the show. And we love connecting with you on social media. You'll find us on Facebook, Instagram, Threads, LinkedIn, X, Blue Sky. Simply search for PediaCast. We have a couple of other podcasts I want to tell you about. If you are a pediatric provider, we do have a podcast for you. It's called PediaCast CME. That stands for Continuing Medical Education. And it is similar to this program. We do turn the science up a couple notches, and we offer free CME and CE credit for those who listen. And that's not only for doctors, but also nurse practitioners, physician assistants, nurses, pharmacists, psychologists, social workers, and dentists. And it's because Nationwide Children's is jointly accredited by all of those professional organizations that we can offer the credits you need to fulfill your state's continuing medical education requirements. Shows and details are available at the landing site for that program, PediaCastCME.org. You can also listen wherever podcasts are found. Simply search for PediaCast CME. And then one more podcast that I host, because two's not enough. Everything comes in threes. This one is a faculty development podcast. So if you are a medical faculty in any specialty, does not have to be pediatrics, just any medical faculty. So if you teach medical students and residents, and you are a faculty member at an academic institution, then we have a podcast for you. It's actually from the Center for Faculty Advancement, Mentoring, and Engagement at The Ohio State University College of Medicine. It's called FameCast. So if you are a teacher in academic medicine or a faculty member in any of the health sciences, then this is a podcast for you. You can find FameCast at famecast.org and wherever podcasts are found by searching for FameCast, FAMECAST. Thanks again for stopping by, and until next time, this is Dr. Mike saying stay safe, stay healthy, and stay involved with your kids. So long, everybody.